Brian Jelen. I'm an internal medicine physician and clinical informatics fellow at Hennepin Healthcare. And like many of you, we at Hennepin have worked hard to set up our telemedicine platform to help our patients continue to have access to high-quality care during these difficult times. At Hennepin, we really started from the ground floor without much in the way of any publicly facing telemedicine options. In this video, I'll take you through some of the basics around telemedicine and highlight some of the areas where telemedicine has been successful in delivering care to some of our most vulnerable patients. We also need to acknowledge that telemedicine is by no means a silver bullet solution. Our healthcare system is not alone in discovering that there are some inherent problems with delivering a high-tech solution to our vulnerable and underserved patient populations. There are many concerns about the equity of care being delivered via telemedicine, and we'll spend some time discussing what we have researched and learned thus far and how we can all move ahead as a community in leveling this playing field. I think it's important to start with some background information and vocabulary when it comes to telehealth and telemedicine. Telehealth and telemedicine are often terms that are used interchangeably. However, they carry different meaning. As you can see here, telehealth covers a broad array of connected health modalities, one of which is telemedicine. More specifically, telemedicine is a virtual modality of direct patient care via asynchronous or synchronous means. Telemedicine has been around for many years, but was thrust into the limelight during the COVID-19 pandemic as a way for patients to safely continue to access care. While the initial growth has tapered off a bit, most projections suggest that telemedicine is here to stay. The reason that much of this is now possible is thanks to several sweeping changes at a legislative level that have made telemedicine more accessible for patients and viable for healthcare systems. Many of these changes were enacted as part of a broader emergency legislative change and will need to be evaluated prior to their expiration in the coming months. It's crucial at this time that our healthcare systems have someone following these changes and advocating for their continuation after the pandemic has ended.
So one example is that since the onset of the shift to telemedicine, there's been, in the last 5 months, about a 50% increase in our patient volumes, mostly driven by access through telemedicine and telephone encounters. The other way that telemedicine has changed our practice is that there are now loosened regulations because of the public health emergency around prescribing buprenorphine. And so we are now able to start people on buprenorphine by telemedicine without an in-person visit. And that has dramatically increased our ability to start people if there's not a provider on site.
So for us, telemedicine specifically helps us provide care for individuals who are in group settings, so group home settings, nursing home settings. Right now, a lot of those people cannot leave.
Our ability to get people in the clinic whenever they contact us within 3 days has jumped to about 70 to 80% of the time. And so that contact for patients has suddenly blown up, and that's a lot of what's driving our ability to kind of reach out and connect with people and then hold on to them, is we're getting them the care they need at the moment when they're seeking to change their lives.
Think about an appointment in the way, from a family perspective, from a community perspective. An appointment costs money. So it's not only the healthcare money, right? But it's that dad and that mom asking for a day off to bring their children to us. And telemedicine has that amazing ability to connect them wherever they are, our patients, without having to waste the extra time that the appointment needed. And even they can even be working.
While telemedicine has been a success for many of our patients and providers, it does not come without some problems that need to be addressed by the healthcare systems in our communities. While this care delivery platform is generally easy to access, it's still not broadly available for all and disproportionately does not resonate with patients of color, non-English speakers, and older patients. Hennepin Healthcare established a steering committee to focus on the equity problem that we are finding with telemedicine. The data that we have uncovered thus far aligns with data healthcare systems are seeing across the country as we all try to navigate this new care delivery platform.
I've got some patients who only activate their phone plan on the weeks that they know that they have an appointment, but otherwise they can't afford it. That's tough. And I think there is a role then for them to be able to come in, and at the same time, it's that same cost of getting on the bus or whatever else is going on in life. It's still just as hard. And for them, the barrier is still getting onto a video visit or a phone, or when they have a laptop that's 15 to 20 years old, it doesn't have a camera that works. I think those are still the struggles that many of my patients still face, that even though the barriers to getting care have dropped so far, it still requires the technology piece.
Although I have to say, like we find out through our research, like, and for what we know at the national level, like the ability of our communities, particularly immigrants, to have a cell phone, it's really high. It's sometimes the ability to pay that cell phone that is at risk.
When I think about people at the jail, it's really common that for whatever reason they don't have phone access when they leave, and that transition is a really important time, and I think that trying to communicate by telemedicine during those periods is a challenge without rethinking how we get people the resources they need to participate. So I think equally as important as the technology is that provider on the other side of the technology. And I think telemedicine should be developed acknowledging that there is implicit bias, that there is structural racism, and I think setting up the infrastructure that acknowledges that reality and that history is a good first step.
So in order for us to correct the inequities that we have seen in telemedicine and kind of like move forward, for once we need to adapt the ways and the access to telemedicine, right? To simplify the access as much as we can, like what we have done here in Hennepin, right? With a link for a text or a link to their email. So if they have computers, emails work better, so they can access the link in the email. If they have their cell phone, the links work better because then it's a click and they're connected. And the other piece is training. So the same way when you're doing telemedicine, you don't need your MA anymore, right? But you can use that function of an MA and transform that as a concierge.
Throughout this presentation, you have seen how telemedicine impacts both clinicians and patients, and telemedicine is here to stay. I would say become advocates for telemedicine, but also make sure that we don't lose the lens on health equity. If you are a caregiver or a clinician, appeal to your professional societies to become advocates for equity when it comes to telemedicine. We have to ensure that when healthcare systems are setting up telemedicine, they have the equity lens on. For payers, both government and commercial payers, I would encourage you to think of telemedicine as a great way to deliver care. However, at the same time, there can be ways telemedicine can be leveraged to actually solve for the equity gap. Advocacy works wonders. So whenever you're advocating for anything around telemedicine, keep the equity lens on and see if your advocacy efforts are actually improving the equity dilemma.
At jobs like Arby's or McDonald's that they can't get work off, and those people can see me via telemedicine. They don't have to take that time off work, miss the hours. I mean, people just can't do that. Those people can still access care.
I think there's oftentimes a mantra in medicine in general to meet patients where they're at. We are literally doing that now with telemedicine. They're not coming to us. We are literally meeting them where they're at, regardless of where that is. A visit in their car because that's their 10-minute break at their job. On the phone on their commute, and it's fitting into their lives as opposed to forcing them to fit into ours. And I think that's the goal why so many more patients are engaging in our clinic, is that we're literally meeting them where they're at, beyond the meta way of cognitively meeting them where they're at for our goals of care, but now we're literally meeting them where they're at in terms of their lifestyle. And I think that's a really exciting change for how to meet people when it's an inherently stigmatizing condition. Stigma doesn't matter when I can meet you literally wherever you feel safe.
Health happens when the patient live, work, play, and study. Well, that's what we are doing with telemedicine, right? We are going to their field and seeing how really they live, and it's amazing. I will not trade this type of care for the other.